Great. Hello, everybody. So welcome to today's event. I hope we're in for a fascinating and invigorating conversation today. Hello, I'm Jenny Ousbey, and I'm CEO and founder of OVID Health. OVID is an international health and life sciences communications consultancy where we create health campaigns that improve the well-being of people around the world. We specialize in blending communications, public affairs and patient advocacy to make change happen, and we are change makers. I'm delighted to be joined by three health change makers today, and without further ado, I will introduce them and their fabulous backgrounds, and then we will talk a little bit about what we're here to discuss today. So I'm joined by Dr. Nikita Kanani MBE. She is a GP, UK UN Women Delegate, Sky News health expert. She's Chief Strategy and Innovation Officer at Athena Health and former Medical Director of Primary Care for NHS England, and currently just finished her morning surgery, so we're hoping for no emergency interruptions during the event. I'm also joined by Dr. Michelle Griffin. She is a gynaecologist by background, BBC Women's Health columnist and strategy advisor in femtech. And finally, I'm also joined by Athena Lamnisos. Athena is a campaigner and CEO of gynae cancer charity, the Eve Appeal. All of these women are fantastic experts in the topic that we're going to discuss today, which is the gender health equity gap. How can pharma and femtech play a role in closing it? So a couple of paragraphs of intro from me on this topic. I think that one of the important things is that we know diseases can affect men and women differently, and we know that it should impact policy development, the media debate, R&D, system readiness, all those kind of components of a well-functioning health system. And yet much of healthcare is still seen through a male lens. But women are fighting back. So we've seen in recent years, we've seen successful campaigns in topics like menopause, for example, but a lot still needs to be done so that we can start to go beyond bikini medicine. And just to start off with some I frankly still find shocking statistics on the gender health equity gap. For example, aspirin dosage is calculated based on men taking part in clinical trials. So women tend to experience worse side effects. Women are 50% more likely to be given an incorrect diagnosis after a heart attack. And additionally, in general, there was a recent World Economic Forum report that showed that women spend 25% or more of their lives in poor health than men. So that's the scale of the challenge that we're talking about today, and I'm very confident that within the next 55 minutes we can basically solve all of it, but we'll have a go. My first question is actually, I think we often start with the problem, but I actually wanted to start to begin with some of the successes. So I mentioned in my intro that, we've had some more successful rising to prominence of women's health campaigning in recent years. So I wanted to throw it out to the women today and say, where have we seen success in women's health? And more importantly, why do you think we've seen some success in women's health campaigns recently? I'll turn to you, Athena, first. Representing some of those more campaigning organisations.
Yeah, thank you, Jenny. Thank you for that. Well, where have we seen success? We're definitely talking about women's health more, but when I say we, I mean we looking at each other. So people who have quite a lot of health efficacy already are talking about the women's health a lot more. It's crept up, well, all the agendas really, corporate, political, certainly the public agenda. And that's been for a range of reasons. Does that play into health equity over this, though? No, I'd say not. Awareness, consciousness, dispelling myths, taboos, embarrassment has happened with very particular audiences. And that is an advantage. It starts conversation. That conversation spreads to corporates, brands, and others who want a bit of that, pie and a bit of that conversation. It doesn't mean that it spreads through everyone and to the people who are facing poorest health. Now, we've really seen that happen with menopause, haven't we? We've really seen the celebrity voices who have been both very helpful, but also quite challenging across some of that debate, I would say. And then we've seen a lot of commodification coming from the back of that. Now, some of that, again, can be very positive, but, you know, I do roll my eyes skyward at menopause shampoos and, you know, teas and all sorts of things. And that, you know, that has happened. But we have definitely started a conversation at policy level, which has been really helpful. I think that the consultation around the women's health strategy, although the women's health strategy isn't fantastic because it's not really a strategy, it's a kind of set of thoughts, ideas, and ambitions rather than it being a work through plan, and it's certainly not funded. It's really helpful in that it collected together a very powerful group of women's voices that said really clear things about health equality, health equity, and across health, because I think that quite often within the women's health kind of debate, we start to sort of shrink that to issues of gynecology, reproductive health, and women's health is all of us. We're not just, you know, a couple of organs collected together. We are whole bodies that bring all of that with us. Just to go back to what you said about you know, the recent kind of economic forum, etc. Marmot tells us, and Marmot has told us for many years, but the recent update has told us women are living in poor health for longer than men. There are reasons for that go beyond the collection of reproductive organs that we have. So looking at the intersection of poverty, demographics, and other issues is vital to this. And there is a part to play from all three sectors. And yes, pharma and corporates have got a very big part to play in that. But to your original question, yes, of course, campaigns have been helpful, but they have also really they've not made an impact on the inequity side.
Yeah, thanks. And I think just picking up on that, I mean, it's interesting, in the UK, we have a women's health strategy, but in the vast majority of the EU countries, actually, there isn't a specific women's health strategy. And I think that's a really interesting one. And I think the other thing is that you've got this, I was interested to unpick what you said with Nikki and Michelle around actually when you have success, sometimes that leads to either a masking of the kind of underlying root causes, or as you say, the intersection or the other inequities, but also that commodification that sometimes that successful campaigning leads to. So if I bring in Nikki, you were nodding vigorously at points that Athena was saying.
I think one of the lovely things about getting this group of people together is we'll all have had very similar experiences, whether that's sort of personal, clinical, or in the policy world. And I was, as you said, Jenny, in surgery this morning. I'm still here. And probably about 60% of my surgery were women navigating either their own care or the care of somebody else. And we know that women are often the person who brings somebody in to the surgery in general practice, in this example, often deprioritizing their own needs to make sure that somebody else gets the care that they need. So to Athena's point about women living longer in ill health, and I'll come to the positives in a minute, you know, but we live about 1,000 days longer than men. 25% of that is spent in ill health, and that's a range of things. Athena mentioned many of them, but chronic stress as well. We're society's shock absorbers, so we walk around absorbing stress, absorbing complexity, absorbing everybody else's kind of societal issue, and that means that women often go to very much the bottom of the pack in terms of being heard. And I think it's really important that we think about intersectionality and protected characteristics here as well. So women who are brown, women who are black are less likely to get the sort of care that they need and that they deserve. Athena, I'm a little bit more optimistic, and actually I was going to come in with optimism on the women's health strategy, but for a very similar point. It's not quite a strategy, but it's a collection of very powerful narratives. And although all of us will have experienced individual cases that these narratives refer to, actually looking at those all together, it's a very compelling piece. As Athena said, relatively small funding, so £25 million, non-recurrent. We've got a little bit of time now with the new government to see where the focus will be. But actually, for me, that is a success, because what that's been able to kind of galvanise is a real focus on women's health in a way that allows other people to come up and sort of stand behind those the principles that are set out in the women's health strategy. So if you're an international caller or listener, the women's health strategy essentially says, because of the complexities and the fragmentation that women experience in their healthcare journeys, one of the answers and one of the offers is around the women's health hubs. Every system in the country should or will have almost like a one-stop shop where women can come in and get the sort of care that they need, either because they're symptomatic and they have period pains and menopause and other things and menopausal symptoms, and or they need to catch up with their smears. Now, I am a almost smear defaulter, so just if you're due your smear, have your smear done, but my smears are offered, not in my practice, but in the practice that I'm registered with, on Mondays at 12 o'clock. It doesn't work for me, so we do need to create a different sort of service offer for women. But I think, as Athena said, women are becoming much more able to talk about some of the things that we rightly sort of deserve in terms of how services are set up and as we access them. The 1,000 days that I mentioned refers to the McKinsey report. It was the $1 trillion report. And I just think for listeners, it's really important to clock that what that also said was, if we were to return 7 days of health to every woman's life per year, just 7 days, that gives us 75 million disability adjusted life years. That's $1 trillion for the economy, the global economy. And I think that actually is a massive incentive for us. So we've got our first female chancellor in our UK government. Actually, as she's going to look at the kind of economic situation, that's a real cause for success as well, I think, Jenny, or driver for the sort of success that you mentioned. And yeah, so I'm going to be optimistic, but I will absolutely love to hear what Michelle thinks.
Thank you. Yes, I think going back to the original question around successes and leading on from Nikki around optimism, I definitely want to bring out from probably my real perspective on looking at the more commercial private sector, and specifically starting with startups. And there has been a massive explosion in the startup space looking at women's health. I think that they have focused on reproductive health, but we're now starting to see that grow even further. I think having reports such as from Deloitte and McKinsey, as Nikki had mentioned, about identifying white space in that bigger area of looking at heart health in women, brain health, for example, is really definitely needed. And I think as we've started to see the churn of these startups and the growth, that's obviously been powered by investment kind of feeding in from the top, which I think is a reflection of where Athena was saying that we have started to see movement on the policy side. And basically, it comes down to a business and what's the return of investment. And we see that suddenly a market that had always been there has now been sort of opened up. It wasn't as though women didn't exist. It was just that we didn't recognise that women's needs within healthcare are not being served. And as women ourselves, we knew that, and as doctors and campaigners and working in organisations, we knew that. But I think really in the last few years, it's been more widely accepted and people are more aware about it. So much so that you're getting much bigger, more established organisations and businesses who are now saying, look, what's our actual women's health offering? When you're looking at health insurance, we're looking at pharma, etc. But I think one thing that I would really want to pick up, which kind of ties in what we've seen so far, is that, as Nikki said, like healthcare systems will need to change. It doesn't fit to just have smears at one time in the week and that would be it. But I think it's a recognition of what healthcare of women looks like And that comes down to what does normal changes in women look like. The healthcare system is set up very much for, if there's a problem, go and see a health professional. And that works for the males. But for women, there isn't really a problem. There's just changes in a lot of situations. So fertility, pregnancy, postnatal, perimenopause. We wouldn't necessarily say there's pathology behind here. There's not disease, but it's just something that needs healthcare input. And what that has led to is that hasn't been there. It's ad hoc, going from one doctor to another doctor. We don't have an ongoing one doctor who's looking after us. And when we look at our European friends, they will have an annual or biannual review with a gynaecologist. This is something we've definitely lost in the UK. And I think this has led to that flourishment of the startups, because a lot of them have said, I've come across this problem, or I saw my family come across this problem. And there's nothing out there in healthcare provision that serves that problem. So I'm therefore now going to actually build a company that serves that need. And so I think at this point, this is what we're seeing, but it feels overall as though we're moving in the right direction. But I'm kind of sitting between Nikki and Athena, I suppose, by saying I'm optimistic, but it's very, very messy. And we haven't really worked out what we need to do and what looks right. I think we've got great views coming in from, with movement like it's the US with the White House initiative. I think Europe will be leading on this in some way, shape or form, taking note from women's health strategy and looking about that. But I think probably on the ground, their infrastructure is more advanced than what we have here in the UK.
Thanks, Orna. And I think that, one of the things that I want to pick up that all of you have said in different ways is that this whole, actually sometimes if the media narrative or indeed the policymaker narrative is such that it's okay, we're talking about women's health, it's rising to prominence, we're dealing with it, actually can be harmful in the sense of it makes us feel like we're fixing it. And actually what we're not doing is quite literally not going beyond bikini medicine. So we're quite literally not going, well, hang on a moment, but bladder cancer produces different outcomes in women, or black women have much greater prevalence of uterine fibroids. And actually, like there's so many examples of when we have there's so much inequality, as you say, so deep rooted in the system. And actually sometimes I worry that this explosion, as it appears from the outside, of femtech companies, or indeed pharmaceutical companies talking about women's health, can sometimes mask actually what's a deeper problem, because it's almost like, well, we'll talk about the things that's easier to fix, because actually it's a lot harder to tackle the systemic challenges. And I don't know whether I'm probably a pessimist naturally, so that maybe that's how I look at it. But interested to know your thoughts on what can we do to help to start rise to prominence the other parts of the conversation that aren't being talked about.
Yeah, well, I'll just jump in here. Sorry, just to say, because I think a big problem of what we see, and that speaks to like the commercialization of women's health and looking for easy to fix, is the lack of money. And so it's like, what's low hanging fruit? What can we do quite quickly? What can we return an investment on? How can we generate revenue very, very quickly? But when we look at research and we're saying, look, if we're doing hardware development, if we're looking at diagnostic research, exploration, before you even get to the point of finessing your diagnostic and looking to scale up and commercialize, which is a whole thing. I mean, Athena, you will know this. We're looking at 10 years is good, more likely 15 to 20. And there's not only a lack of funding, but there's a lack of appetite to say, right, do I really want to invest in something where I'm looking at a return of investment in 20 years? And I think the problem we have is that we keep banging the drum saying, look, it's around 50% of the population are women. So when we look at healthcare of women, this is not niche. There's a market here. There's obvious need. And we can do like the diagnostics and things which look very much like reproductive health, like endometriosis, which isn't really, it's a whole body disease, but if you want to call that reproductive health, that's fine. But equally, if you want to look at something around cardiovascular disease, in women, you've got all women and their risk of cardiovascular disease. I think the disconnect we have is that while we have large numbers, we have this feeling and this inherent belief that the current infrastructure and healthcare service provision globally, in all the differences and flavors we get across the globe, they still cater to these needs. And therefore, the kind of business case looks more like, oh, well, it's only a small proportion of a small proportion, so that sounds a bit niche to me. Because they're like, well, you've already got an emergency services, you've already got a cardiovascular heart attack pathway, we've already got this for bladder cancer. Why do we need to do anything different for the women facing bladder cancer, whether it be on diagnosis, investigation, or treatment? But of course, it's a recognition that really we're looking at something completely different, because we're looking at bladder cancer, but it's inside that female body, where it's a completely different environment, as well as also the kind of social, psychological, economic situation that has different influences on a woman going through a bladder cancer versus a man going through that. And I think that disconnect needs to be put together so that people can see that they're really, the market's there, but there is a real return on investment.
Thanks. What do you think, Nikki? I think you were going to come in.
Just a really short comment, but I think important, and maybe just to help your pessimism, Jenny. Masking is really common in big societal shifts in community campaigns. So I rolled out the COVID vaccine programme, and for we're tracking the data sort of 20 times a day, and for weeks and for months, both internally and with our political counterparts, we're looking at the macro numbers and going, numbers are going up. This is great. There's no issue anywhere. And obviously, of course, as we dug into the data and we looked at different ethnic groups and different communities, you could see where there were massive discrepancies. It would have been really easy to say, the global number of white 70-year-olds getting vaccinated is good, so we're okay. But the power of the data, and actually, to Michelle's point, is that we need to use data to show where our gaps are and where our opportunities are. And I think we are coming into this with lots of scars on our back from different fields and different levels of expertise and experience. So making sure that we've always got that eye on the data at the intersectionality of kind of the different communities we're here to care for will help us to kind of unmask those issues, and really give an offer that's much more bespoke to the different communities that we're here to care for.
Thanks, Nikki. And Athena, do you think that the media, I hate portraying the media as an amorphous blob, but for the purposes of the question, I will. But do you think that the media play a role in kind of pushing we'll talk about reproductive health, or we'll talk about bikini medicine, but what we're not interested in is talking about when we go deeper in terms of that kind of gender equity piece? Do you think that the media have a role to play in that? Do they need to shift?
Yeah, I mean, absolutely, in the stories that are told. But just picking up on what Nikki just said, I mean, I think that hits the nail on the head, really. And I'm very optimistic about how things can change. I am very realistic about how the rise of women's health is something to discuss, and a policy issue has not really benefited those who are most unequal when it comes to health. And I think that is not a reason to be pessimistic, but is a reason to really look at the data and really understand that it hasn't benefited everyone. And that partly is because of what's around us all, whether it's social media or traditional media, and it is very difficult to talk about the media as a kind of amorphous lump, but it's the stories we hear, it's the voices we hear, it's the faces we see. And what we're not seeing is the inequity. We are not seeing the intersection of poverty with health. We are not seeing and hearing those stories. We are hearing very, very different ones. So yes, I mean, being much more sophisticated in terms of the stories that are told and the way the data is represented in those stories and talked about is really, really very important. And I think that just going back to something Michelle said, really what you're talking about there is funding prevention and funding longer term, and those have got to be the answer. We can't look at 1 year, 2 year, 3 year strategies here. We've got to fund for at least a 10-year horizon. We have got to fund prevention. Everyone knows that prevention is better than cure when it comes to health, and everyone talks a good game about supporting it. And indeed, we now have a government that's put prevention at the heart of a lot of its manifesto pledges around health. But that needs funding. And you can't achieve anything without funding. And to go back to what you said, Jenny, yes, we're not seeing women's health strategies, well, either present in many countries or funded, but we are in the States actually. And people can say whatever they want to about Biden at the moment, but the way that that women's health has been centrally funded and the focus on preventative health is really very impressive, and you can really see how in a UK context could unlock something. We call it a national health service. Really, it's a national treatment service. It's there to pick you up when you're broken and not to put keeping you healthy through your life course at the heart of the care. And that's what we need to see. That's the kind of quantum leap that we want to see. And if the media told that story more effectively, that would be very, very powerful.
Yeah, I just come in there. I completely agree. I think the big thing, because obviously at the point, women's White House initiative in the US was somewhat lagging, if at all, in that UK had already come out with the women's health strategy. There had been various grants and funding and research calls across Europe as a whole, and US was sort of quite quiet. And I definitely feel that there was this, like, what are we doing here in the US? And then obviously to come out, I really do believe that is a quantum leap, because it came out at the very highest and it came with a significant amount of money. Now, obviously we could always ask for more money, but I think it was a real nod to say that we don't think this is a quick fix. This isn't a few women somewhere struggling a bit, that we just need to look at one particular area or one particular geography or one different slice of the population when we look at social, economic, when we look at ethnicity, etc. It was a widespread, we recognise and we will not accept that there is a disparity and there is a lack of health equity between men and women across lots of different ways you want to cut the pie. But women are on that negative side, and therefore we need to do something about it. And the call to say, look, we need this across research, we need it across healthcare provision, we need it in corporations, we need it in employment, we need it in education, like at school level, was, I think, a really significant move to say, look, what we've done so far is just substandard across the board, and we need to change that. And I'd love to see that mirrored elsewhere. I think we've kind of tried to get there in the UK, but we haven't quite got that messaging out.
No, I'd agree. I should agree. From an OVID Health perspective, from a communicator, storyteller perspective, I understand that the role that we can play is about articulating those messages, uncovering the challenges, telling the story, and using powerful stories to get there. But thinking about a lot of people listening today work in the life sciences industry. So what role do we think either the life sciences industry as a whole or individual pharmaceutical companies or femtech companies can play in addressing that inequity, as Athena put it, and also tackling that broader prevention agenda when it comes to thinking about women and their health rather than women's health? Nikki, any thoughts?
Yeah, I mean, I think it's a great question, and one of the things I reflect on a lot in the last few months. I'm part of the founding team for an organisation called OVID Health, which is, you mentioned, a women's health service, which is very much reflects the principles and the way women live their lives in the way that we've discussed. So it's, holistic life course care. We are not just one painful period or endometriosis or our challenges around our menopause, but we are women in all of our brilliant ways and need to have care as such. But one of the things that our organisation does is offer a range of femtech products within the wider clinical and physical offer. So what I've reflected is we have got we've come across sort of 800 femtech products in this space. I mean, it's incredibly confusing, but I think what's amazing as well is that we have the distinctly feminine desire to work together collaboratively, and the people that we're speaking to in the femtech space are exactly the same. So where I think and I've commissioned many services in my time, and many are not as female led as this space, so it would always feel quite competitive and quite a challenging space to be in. Right now, people that I talk to really do want to work together to help support the different communities that we've touched on. My daughter's 12 and she'll use a period tracker, but actually what's really exciting is when that period tracker is able to then influence her understanding of her reproductive potential, and eventually her personalised HRT as well. And you mentioned sort of the responsibility of partners to think about the different communities. We now have wearable cordless breast pumps, so that breast pumps that you can have in parts of the community that's quite rural, and we have scanners that are portable prenatal scanners that can be used in really remote areas, so that you can improve access to prenatal care in traditionally underserved areas, which is often areas of deprivation as well. And so you've got all of these fantastic kind of femtech people thinking about not only how to have great products out there, but great products that allow remote care in underserved communities as well. And I think as commissioners or service designers, we've got real onus to then look at those products. And if they aren't saying, this is what we're doing to reduce health inequalities and improve access to care, then actually as commissioners and service creators, we should be asking those questions and making sure that we're creating communities of providers and femtech gurus who really do want to serve the many and not just a few.
Thanks, Nikki. Athena, any thoughts?
No, I mean, I think Nikki covered it very well, actually. I mean, I think it is that looking at all of the different barriers and challenges to accessing services. And this is not like food colouring into water. There isn't one challenge that you can sort out that will suddenly solve everything for everyone. Nikki highlighted a barrier around, working time and attending screening tests. Other people will have barriers around absolutely no awareness of signs and symptoms or what cervical screening is for. That will be their barrier. No information has been provided to them about how to access. I think if you look through the lens, though, if femtech, brands, pharma, all of us looked through the lens of inequalities and really understood the barriers for different audiences, so broke down different audiences, so those affected by learning disability, those affected by physical disability, those affected by sexual trauma, those affected by FGM, those from different communities where there might be language or cultural or knowledge barriers or whatever the barriers might be. Break down those challenges, and then look at your service, your innovation, what needs to be fixed through that lens, and you'll be fixing it for the many. Again, going back to something that Nikki said about women's health and their impact on family health. About 80% of the healthcare decisions in any family, including for their partners, if their partners are men, are taken by women. They make the decisions about their own health, they make the decisions about children's health, and they make the decisions usually about their partner's health as well. And so if you solve that through that lens, you're solving it for everyone, which is a huge win-win. and really would be a very useful lens to kind of look through, and make sure that you're focusing on those specific. I mean, it comes back to the data as well, doesn't it? We have perceptions about what the barriers and challenges are, and they're sometimes very different to what the actual barriers and challenges are.
I love that, and one of the things that I'm constantly talk about in the office is about how do we harness that kind of childlike curiosity. So it's always like, but why? But why? But why that? And I think that actually that, you know, that I was smiling when you were saying that, Athena, because I think we don't ask enough of why. I think there's quite often I'll come across a particular disease or an illness or a diagnosis where we're asked by a client to think about how we communicate XYZ challenge on it. And then we'll go, well, you know, women have poorer outcomes. And then actually, when you dig deep and you look into the evidence and you read the academic journals, actually, there's no scientific consensus necessarily on why women have poorer outcomes. And it's just, well, yeah, but they just have longer hospital stays or they just have poorer outcomes. It's like, yeah, but why? Well, no one's funded the research to actually find out why. So, you know, I think that's one of the fundamental issues, isn't it? I'm going to move us on in the last kind of, how long have we got? There you go. 10-15 minutes in terms of thinking about where do we go from here. So we're all violently agreeing with each other. So maybe we can have some debate in terms of what we think are the most effective ways to solve some of the challenges that we've outlined. So I'm interested in responses to think about, you know, how can we bring everyone else on this journey with us, because we're kind of knowledgeable. This is what we do in our day-to-day lives. So how can we bring that through to the masses? How can we bring it through to policymakers or journalists or those in the media? And actually, part of that maybe consider, and whose voices should or could be amplified further to help with that advocacy piece. Michelle, any thoughts?
Yeah, I mean, I know you're wanting debate. I'm going to somewhat agree because we all are in agreement, but I'm a massive proponent of data, and I think it reflects what everyone's been saying today. You know, there are specific needs of healthcare in women, and that gets broken down into diverse needs, talking about the barriers. And when we think about health equity, and I think the thing is that at the moment we're in a place where we're not recording it, and so we can't change it. So we have data, but it's at a very large level. It's at population level. It's not even sex disaggregated level. And so we can't get to the ins and outs. Yes, there are specific things when we look at, and I'm sure Athena will be an expert in this, but screening numbers for cervical screening, breast screening that happens in women. Yes, but we can't say that's the whole of healthcare for women, as we've talked about today. So I think generally speaking, rule of thumb, we can happily say that we've got aggregated data. And it's great to see that, that WHO has come out earlier this year with the SAGES guidance saying that actually a standard needs to be that in clinical trials, you need to be doing sex disaggregation in your data. But even more so than that, you need to be planning your trial, your protocol, thinking about your recruitment retention strategies, thinking about your analysis strategies and your data presentation around sex disaggregation, and also go even further and reflect the diversity and the needs within your female population of your kind of cohort. I think if we started from there, the great thing about the data is that you can't argue with it. You can argue with the analysis potentially, and you get lots of statisticians coming in and disagreeing with things, but ultimately you can't argue with the raw data. And I think there is a lack of detail and nuance at the data level that we're at the moment, because it's so high level. We are really missing, and goes to Nikki's point around COVID vaccine uptake. And we could have easily gone, yeah, the numbers are increasing and we're doing fine, without saying, no, we need to dig in deeper. Who are these people who are being affected by it, and how are they being affected it? And we then need to run that across all of women's healthcare, not just the bikini medicine. And so I would really want to see that has got to be the kind of foundation to move things forward. And what comes to be able to push that forward and accelerate that is funding. But it's really interesting that when you hear the likes of the Gates Foundation saying we're ready to fund it, but until you show us the data of what we will be funding and the type of impact that we're looking to have, how can we fund it? So we are in a bit of a vicious circle there, and we need to work out how to break it. But I would really be looking at that. Probably a lot of this data already exists. It just hasn't been collected and cut yet the way it should be. So I would be looking to, as you said with the audience today, a lot coming from the pharma background, is actually saying, look, what can you reanalyze? How can you go back in and look at it with this lens on, as we've discussed, and actually let's get some movement on that side, rather than this low-hanging fruit and looking at this very kind of quick commercialization route that we seem to be heading down quite a lot at the moment.
Thanks, Michelle. And Nikki, aside from,
Yeah.
I'm guessing you're going to agree on more funding. I think we all would. Lisa, any additional thoughts?
I was going to be kind of slightly prosaic and then maybe a little bit more creative. I was at a surprise 60th at the weekend for my uncle, and about 80 people there, and obviously, well, not obviously, but sort of 90% of them were Asian, and most of them were women. And it was really interesting because obviously the first thing that everyone asked is, so what are you doing? And how's your job? And how's an hour going? And I was talking about it. And what was amazing about this is all, the majority of women were from sort of 45 to 60, and all they wanted to do was talk about, in this case, their menopausal symptoms or their menopausal history. And the really clear message I got was, thank God, I have not had a chance to talk about this in my Asian community. We don't really talk about it. So not only do we not talk about it, we don't normalise any part of it, whether any of it is normal or not, but we don't normalise what our symptoms are. We have no reference points, so then we don't know when to ask for help, and then we get sicker quicker and we stay sicker for longer, as I mentioned at the beginning. So I think the really prosaic bit is, and maybe this is something for you, Jenny, how do we keep as health commentators and communicators keep creating spaces for these conversations in communities? That's not to put the onus on the community to fix the issues in women's health, but to create conversations where they can be the role models and they can share their experiences, so that then other people in the community can kind of go, oh, okay, I can now talk about whatever issues that I'm having. So really obvious thing, but really important, and people who are listening in today will have versions of that, whether it's in their own community or in the communities that they serve as part of their roles and their day jobs. And then the more kind of exciting point, I think, to Michelle's is how we get really creative with our research. So I can't add much more to what Michelle's said, but at Anara, we have a really strong scientific backbone. So collating, pulling together lots of data, which will allow us to do the bit that you described, Jenny, create services that make sense for women. Your point at the beginning about heart attacks and women, it's not just that the services don't make sense for women. Women's symptoms are often different as well. They describe them differently. So to the kind of early parts of the conversation about how do we talk about particular conditions from a distinctly feminine lens in languages that people understand, in a way that then changes the way that services are designed. I think we've got a lot of the tools and the incentives at our hand, but we do need to. We're the generation that's on a band to really turbocharge it now.
Yeah, well, firstly, I think we can all, as imaginary policymakers, call for more birthday parties as a way of solving the conversation around women's health. I'm all for that. But I on a serious note, I agree with you, and that sounds like a really bonding experience, frankly. I think the other point is that, language matters, right? I remember there's some super interesting, very geeky work that's been done around how women describe pain differently. So, we know women use similes and metaphors more when they describe pain than men, and that matters, particularly if you have a male healthcare professional talking to you about your symptoms. I'm going to move on to the last bit of the conversation. So I did warn these guys in advance that I would do this. So I thought it would be interesting. We've had not just UK elections, we've had an immense amount of elections going on this year. 2024 is the year of the global election. And, you know, I think we could do worse than have Nikki, Athena and Michelle as our dictatorial but benign world leaders. And what would be lovely is we've seen lots of election debates, but I'd like them to think about, imagine that you were world leader for the day and you had to persuade the public that you were going to tackle some of these challenges and seize these opportunities we've talked about in terms of how we can improve women's health. And what would you do? Imagine you had all the funding in the world, because of course you would, because you are a benign world dictator. So Athena, I'll come to you first. You know, what would you do? How would you wave your magic to make a difference?
I'm far too much of a control freak to just name one thing. So, I mean, I think there are a few things. A really important facet has got to be to have a approach to women's health that's underpinned by a well-funded, well-scoped research strategy, a life sciences and research strategy that's really intentional about plugging the gaps, really intentional about making sure that investment is going in to really underinvested areas. That's one thing. The other is to really break down where there is some low-hanging fruit where we can make a big difference, because I think this needs to be approached like kind of, you know, the British cycling team. It's not about changing one thing, it's about finding those incremental great gains across underserved audiences and making those gains. Now, it might be with Southeast Asian women in talking about menopause. It might be across a whole range of other factors, but there are audiences and issues that we could pick off where we could make big wins. And I think that work just hasn't been done. We too often take a one size fits all approach, like we're just going to solve cervical screening by talking to everyone about cervical screening. That will not work. Going back to the COVID data example, you could, you know, that might increase numbers, it won't increase numbers in the underscreened audiences. And then the third thing, and something to really take heart from the new government, is we need to take a kind of task force. They're calling it a mission-led approach. You don't solve health just by looking at health. You need to look across a whole range of other factors. So taking a mission-led approach, as I understand it, means looking at health with the Equalities Minister in the room, with the Life Sciences Minister in the room, with the Housing Minister in the room. And I think that's very, very important and a real difference. Treasury, very important, having money in the room. You know, we've got to look wider than just thinking health is, you know, going to the doctor, going to secondary care. It's not. It's just not. It's about really taking that kind of mission-led approach and understanding the role that health plays and how it intersects with so many other factors. That's what I do. Don't know if it takes a day.
That's all right. We'll give you a bit more than a day, but I think that I was smiling there because I remember that when I was a political advisor to a UK health minister, trying to get meetings where someone from the Department for Education was in the room was nigh on impossible, because it was, well, we're education, your health. We can't possibly be in the same room together talking about potential policy solutions. So I hope in the time that I've been out of politics that's changed. Nikki, what would you do with your day of benign power?
Does it definitely have to be benign? I think I'm gonna build on Athena's points actually, because they're really well made, and that diversity in the room, professional background expertise is huge. A slight addition, and I know I'm sure Athena's in the same place on this, but there's that amazing Angela Saini quote, and she wrote Superior and Inferior, which kind of describes a lot of the inequity that we've touched on. And she said, in the history of science, we've had to hunt for the women, not because they weren't capable of doing research, but because for such a large chunk of time, they didn't have a chance. So it's having that diversity in the room professionally, but also being really, if I was in that position for even a day, you know, finding all these incredible women who are going to kind of keep flying the flag and pushing forward on the agenda items that we've talked about. I think Of course, I'd say funding, but actually for me, it's longevity of funding for longevity of life. See what I did there? Because so far, I mean, I've in my past pre-pandemic negotiated a 5-year deal for general practice, and that was pretty unprecedented at its time. But we still had to renegotiate the contract every year, even though it was a 5-year deal. So you didn't have that kind of consistency and clarity that the 5-year security offers. And I think what we should be doing is a kind of 10+5, or a 10-year women's health strategy with a 5-year review point or something, so that people can really focus on funding community organisations or parts of the voluntary sector or education in a way that doesn't give the benefit in 6 months or 1 year, but might do in 3, 4, 5, 10 years. I think then there's some really clear kind of legislative things that I just so the benign bit is what I'm referring to here, is just legislation around equity, around maternity leave, and protections around workplace discrimination, about gender-based violence. This is very much about women having the right to safety and choice and equity. So those legal protections, they would be kind of day one measures so we could start reaping the benefits, and that would allow economic empowerment and education for women into generations to come. So a few small things there, Jenny, but incredibly and eminently doable, I think.
Yeah, absolutely. And I would add to that list my own kind of personal little campaign around shared parental leave, and actually making it a more meaningful policy, I think would make a massive difference as well. Michelle?
Yeah, well, I feel like any government's going to come knocking, aren't they? I mean, these are all great ideas, and I think like we just need to crack on and do it, almost at the pace that Labour's potentially going at the moment in the last 3 or 4 days. But I think I would do all of the above, but I would take a slightly different route to add rather than instead of, and that would really be looking at more like honing in on healthcare provision, and a little bit more of a kind of ripping up what we have in place at the moment for women, because it's what we've just done is taken what we've got and just said, well, that can be applied all with a few tweaks because you've got ovaries or whatever, and actually saying, no, we're going to start with a blank sheet. And this will be at the level of high level of what kind of professionals are available. So it's not just about saying the GP and a gynaecologist, but saying, look, what are all the different type of professionals that we might need, and the way that they interact and how often they interact with a person, but also just seemingly straightforward, but just looking at the kind of way that we speak to women as patients in the healthcare system, the day, what we're taking when we're trying to understand what their symptoms are, what their signs are, how we're examining them, the type of investigations that we're doing, the metrics that we're using for those investigations. A lot of this data sits out there. And when we think about Athena speaking to this real push in the science and the research side, making sure we translate that over to the clinical side, so that a woman actually feels there is a difference here. Because I think something that comes out time and time again whenever I've gone to speak is that we can talk about all of these things, but when you actually say to someone who is speaking to someone who is a patient, they'll say, I haven't noticed anything different. And that's what we all really need to focus on, the translation piece here, and saying, right, we're going to have a completely different medical record. You've got a different array of investigations. And rather than doing tweaks around the edges, we say, what do we actually need when we're looking at healthcare for women? What do we need when a woman walks into a accident and emergency? What should we be thinking about? What do we care about with regard to the medication they're taking, with regard to where they're at with their screening, where they're at with their kind of hormonal state around contraception, perimenopause, pregnant, postnatal, where they are in their cycle, what they're doing with their period tracker and everything, and actually having a much more inclusive way to say that these aren't just nice to know facts that you kind of supplement something with. These are fundamental building blocks of understanding what's going on with this woman from a health and wellness point of view, and just to write them off and say, well, I'm in respiratory medicine and I don't really care about what drugs you're taking for contraception. It's just, we know is wrong. And we've got to change our thinking and stop just making tweaks around the edges and actually completely create a healthcare system for women.
Thank you. And I think, you know, I would summarize in our kind of journey today in terms of talking about it. I think it's A, we need some radical thinking. B, we need some funding, but funding in the right places and based on evidence. I think we need to either find the data where it is already there or make that data more prominent and make sure it's there. We need to help that the media and the policymaker and the more public conversation really seep in, and we need to use the stories of women from all different types of backgrounds and experiences to really bring that to life. And ultimately, I think it's about the role of the pharma and the femtech industry has a role to play, whether that is about research and data, whether that is about communication strategies or about funding in R&D, or frankly redesigning clinical trials so that they work better and for women, so that, you know, the next 30 years, the next 50 years, we're looking at data that is genuinely based on a true cross-section of society, because ultimately, you know, they are the medicines and the innovations of the future. And I think the final thing is that I hope all of you that have been listening today, you're very welcome to join our cabinet of benign dictators as well, in terms of how we can improve women's health now and in the future. And I hope you've really enjoyed listening to the conversation and given you food to the thought and some good reading materials as well. You've had some good recommendations here today and places where you can go for further information and statistics. We'll make the recording of this event available on OVID Health's website, and we'll put out a link on LinkedIn as well. So please look out for that. Do put in the comments on LinkedIn any of your thoughts and reflections, and hopefully we can all go out into the world today refreshed and invigorated to be advocates, to be change makers. Thank you very much, all of you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.